look at this image. What is T1 or T2?
The
This is your
T1.
This is T2, this is T1. And you see, this is looking white, this is looking black. That means this is modic type 1. Okay? So modic type 1 means there is edema in the end plate. And in some of these cases, there is a chronic inflammation because of the low-grade anaerobic infection. So there is a hypothesis that this modic type 1 can be because of the low-grade anaerobic infection, and antibiotic might be having some role. And this modic type 1 normally presents with diffuse lower back pain, which is aggravated on sitting. Now look at this image. This is your T1 or T2?
So this is
First
T2.
one is T.
T2. This is
Second one is T2.
T1.
T1. And you see the end plate changes looking white, and it is looking white both here as well as here. So what is this whiteness? Is it fat or
because
water?
of fat.
Fat.
Because of fat. Very good. So this is called modic type 2. That means if end plate changes are looking white in both T1 and T2, then it is modic type 2. And this is because of the fatty infiltration. And this is harmless. This is not associated with any pain. Normally, some says that the type 1, they are basically converted into type 2 because of the fat infiltration. And then look at this one. This is T1 or T2?
T1.
T1.
And this is
T2.
T2.
T2. And what is looking here?
Black.
Fat or fluid or nothing. So basically, there is no fat, no fluid.
Or fibrosis.
It is basically sclerosis. It is fibrosis. That means it is called type 3. So modic type 3 means there is fibrosis or sclerosis, and it looks black both in T1 and T2. That means type 1, let me repeat, type 1, modic type 1 means T1 weighted image will be looking black, end-plate black, and end-plate white in T2. That is modic type 1. And this is because of the end-plate edema. And that is might be responsible for pain. Next is modic type 2, where both is looking white. That means it is a fatty infiltration. It is not associated with pain. And the modic type 3, both is looking black. That means there is neither fat nor water. It is some kind of fibrous or sclerosed tissues. And this is type 3, and it is also not associated with pain. Is it clear to everybody?
Sir,
Yes, sir.
initially you had also told that blackening suggests dehydration. So,
just let me just make it very clear.
somewhere
Black means
in
dehydration in some situation, not always. Just listen me. T1, which will be looking white. Just remember this like a mantra. So
fat
T1,
and adipose tissue.
fat will looking white, and the structures which will be looking black, where there is no fat, it will be looking black. Little bit of fat, that means some gray. More fat, more white. Less fat, less black. That is in T1. And in T2, water, white. No water, sometimes we call it dehydration, sometimes we call it sclerosed fibrous tissues, because in some test tissues there is no the water at all. So it doesn't mean that it is a dehydration. Dehydration is a specific condition. So there is no water means that is looking black in T2. But remember that it can be because of fat can also look white in, even though there is no water, even the fat can look white. So in T2, both fat and water will look white. And what will be looking black? But there is no fat, no water, that will be looking black. And then modic type 3. So modic type 3 is your, both is your, or sorry, I was asking T1, T2 and STIR. STIR, what will be looking white? While there will be water, that will be looking white, and no water is looking black. Fat doesn't play any role here because fat is being suppressed. Okay. So I hope doubts are cleared.
Yes, sir.
Okay, just give me 1 minute time. Just I actually. Principles of the ready frequency. So Please listen it nicely, and any doubts we can discuss it later. Can you see my slide? Can you see my slide?
Yes, sir. Yes, sir.
Okay, okay. Thank you.
Yes.
Okay, so let us start. Before going to the radio frequency, first I'll be talking about what is called neurolysis. Neurolysis means you are ablating the nerves, right? So you are ablating the nerves for why? For what are the purposes? What are the indications? Why you are going to ablate the nerves? So most important reasons for ablation of the nerve is you're ablating the pain-carrying nerve to give a good analgesia, to give the pain relief. That is the most important indication for doing a neurolysis or ablation of nerves. But sometimes this ablation is also done for the spasticity. You can remember that if there is a lower motor neuron lesion, that means if you are ablating the peripheral nerve, motor nerve, what will happen? There will be denervation flaccidity. There will be flaccid paralysis. The muscles will be relaxed. So if there is a spasticity for any reason, say for example, if it is a spastic cerebral palsy, or if there is a spastic hemiplegia or paraplegia. So here, mostly the spasticity is because of the upper motor neuron lesions. And here, if you're doing a peripheral nerve, motor nerve lesion also, there will be flaccid paralysis, and that is another indication. So if you're asking you why there is a need or what are the indications for the neurolysis or ablation of the nerve, so the answers are, there are two important indications. One is your pain relief, and second is your to give the relief to the spasticity by doing a lower motor neuron lesion. Now, what are the ways you can do a neurolysis or ablation of the nerve? So ablation of the nerve in the pain, there are a lot of indications. Most important indication is of course the cancer pain, but there are a lot of other indications. Nowadays, even for the sacroiliac joint, facet joint, we all are doing the neurolysis or ablation of the nerves. But in the earlier days, few decades earlier, so that time the cancer was the only indications, but later on all the other indications are also been added. So now the neurolysis can be done by several ways. One, the oldest way is your surgery. You're opening it and you're cutting the nerves. In fact, if somebody is of my age, in 80s, 90s, we have seen a lot of cases of open sympathetic, the denervation. I don't know if some of you have seen or not, particularly in the Burgess disease. Burgess disease, surgeons used to open it and do the cutting of the sympathetic nerve. So those days are over. Nowadays, open sympathectomy, we just can read in the history book. We have never seen it nowadays. It is not needed because if you can do something by percutaneous technique, why you'll do the surgery? But in some areas, again, surgery is coming back again, particularly because the surgery is having the very high success rate. You can do it by endoscopic. Means endoscopically you can find out the nerves and you can ablate it. That is the newer technique. Particularly this endoscopic surgical denervation is seen in the facet joint, in the sacroiliac joint. They are the areas where these procedures have been applied with a very good success rate. But again, these are not very common. Mostly the neurolysis is done by the other ways. One of them is chemical neurolysis. Chemical neurolysis means you are injecting some chemical for the neurolysis. What are the chemicals which are approved? These are alcohol, phenol, glycerol, and hypertonic saline. So these are the four chemical agents till now it is approved. And there are a few others. If you're reading in the books, there are a lot of other chemicals which was used earlier and basically of historical importance nowadays. Those are not used. Still can be done in the animal experiment, but not in human being. For the human being, these are the four important chemicals which are approved: alcohol, phenol, glycerol, and hypertonic saline. So I'll be talking a little bit about the chemical neurolysis before going to the radio frequency. So first of all, alcohol. Alcohol is one of the very important. What are the indications? Why you need to do the chemical neurolysis? And what are the advantages, disadvantages of the chemical neurolysis? Advantages, suppose your target is big and you know that with the radio frequency or with the cryo, you cannot make a big lesion. Say for example, it is a celiac plexus. So celiac plexus, where it is situated? It is situated around the celiac trunk. Its size is big. And not only that, it is around the celiac trunk. So there, ablating the celiac plexus is almost impossible. Why? Because in the center of the celiac plexus is your celiac trunk. You cannot destroy that celiac trunk, number one. Number two is the target is so big that with a probe of radio frequency, you cannot make the lysis of the whole of the celiac plexus. So celiac plexus, it is one of the very, very important indication where still now, the choice is your chemical neurolysis. So if you're asking, tell me one indication for the chemical neurolysis still done nowadays is your celiac plexus. Two other areas where sometimes it is done. One of them is your superior hypogastric plexus. As you know, superior hypogastric plexus is, where it is. It is in front of the L5S1, in between in the bifurcation of the aorta. Again, here also it is a diffuse one. Still, a radio frequency or cryo is possible, but again, the chemical neurolysis gives a better success rate. So they are the 2-3 areas where still can be done. Other areas has been replaced, like ganglion impar block, lumbar sympathetic, splanchnic, T2, T3 sympathetic. So all these areas nowadays, the chemical neurolysis is not advised. So what are the disadvantages of the chemical neurolysis? Advantage, I told you. What is the advantage? That it can cover a bigger area. So this is the advantage. But disadvantage, that if it is spilling to or it is going leaking to the area which is not your target. Say for example, you are doing a splanchnic now, or you are doing something close to the spine, and your alcohol is going leaking into the foramen. Foramen means where the nerve roots are coming, and your nerve root might be ablated. So it's very dangerous conditions. Patient can lead to the paralysis. So if you are given the chemical, there is always a chance that it is spilling or leaking to the nearby structures and cause a very bad serious damage. So very important is, if you are doing the chemical neurolysis, nearby structures, there should not be any nearby important structures. Like say for example, stellate ganglion block. If you're doing the stellate ganglion block here, then what are the structures nearby? There are brachial plexus, there is recurrent laryngeal nerve, there is phrenic nerve coming down. So if your alcohol is spilling into those nerves, what will happen? Recurrent laryngeal palsy, hoarseness of the voice, bilateral means patient is gone. Brachial plexus, your hand might be, the paralysis of your hand. It can cause a phrenic nerve palsy. So all these serious complications might be there if you are injecting, the alcohol here. So don't imagine of injecting alcohol in the stellate ganglion block, particularly anterior approach. So there are alternatives for that. T2, T3 block can be done, but don't think of it. So here you can inject only local anesthetic steroid, or sometimes you can do the pulse radio frequency, but never of the chemical neurolysis here by the anterior approach in the stellate ganglion block. So the very important disadvantage of the chemical is what? That this might be leaking, and it will be damaging your surrounded very important structures, which is not your target. So this is the advantage and disadvantage of the chemical neurolysis. Another very important disadvantage of the chemical neurolysis is there. So sensitization class was not complete in your day when I discussed about the pain pathway. Let me talk a little bit about it so that you can understand this part very nicely. So when there is a peripheral nerve, so peripheral nerve means it's a mixed nerve. There are some motor fibers, there are some sensory fibers. In the sensory fibers, again, the large diameter A beta fibers, smaller diameter C fibers, A delta fibers. There are a lot of fibers together is a peripheral nerve. And when there is a damage to the peripheral nerve, the nerve might be regenerating. I'll be coming to that at these points later on, at which nerve, what kind of damage there is regeneration possible, and what kind of damage regeneration is not possible. So remember that if there is a complete damage, if you're separating it, it's not possible. But if the membrane nerve is still intact, then there is a possibility of the regenerations. But these regenerations may not be always perfect. So what happened? This is a part of peripheral sensitization. You remember what is sensitization? Sensitization means amplification of the pain signals. That is action potential what is generated in the periphery, and it is traveling to the brain through the different nerves. Then if it is dampened, reduced, that is called pain modulation. And if it is increased, that is called sensitization. Sensitization has two important parts. If it is happening in the peripheral nerve, that is called peripheral sensitization. And if it is happening in the central nervous system, that is called central sensitization. Now, in the peripheral sensitization, there are some components are there. One of the important component is your
No sound. Sound has gone.
No voice. So no voice.
Hello. Hello. What happened? Hello. Network connection.
So when the nerves are regenerating, what should happen? That A beta 5 with A delta. But if am I audible?
Sir, there was some problem. So for last 1-2 minutes, your voice was not audible.
From this slide, yes.
From this slide, actually.
Am I audible now?
It's audible, but not very clear.
I actually changed my network setting. Just see whether I am audible or not. Otherwise,
Now it is better. Now it's much better.
okay, fine. So I was talking about the peripheral sensitization. I was talking that what are the disadvantage of using chemical in the neurolysis, and to understand that, you should know about the peripheral sensitization. I was talking about the two important areas. One is when you are ablating the nerve and the nerves are getting regenerated. So there is a possibility of crosstalk. So I was explaining what is crosstalk. Crosstalk means A beta fibers should be joining nicely with the A beta. One end of the A beta should be joining another end of the A beta. A delta one end with the another end. And there should not be any interconnection between it, cross connection between them. But in this kind of pathology, abnormality, what is happening? Suppose you are touching, so it is going via the A beta fibers, and now because of the crosstalk, it is crossing over to the A delta fibers. So what will happen? The touch will be converted into pain, allodynia. This is one of the mechanisms of the allodynia. So this can happen in regenerations, which is faulty regeneration. So this can happen with a chemical. If you are doing a chemical neurolysis, particularly with the alcohol, this kind of faulty regenerations might be happening. Another important things to remember, that is called ectopic signal generations. So if you are cutting the nerve, or if you are ablating the nerve, so what will happen? The nerve cell body is called the powerhouse. Means all the protein manufactured there inside the nerve cell body, and then they are transmitted to the periphery via the axons and dendrites to the cell membrane. You can remember, cell membrane is having two lipid layer, and in between there is a protein layer. And in the protein layer, some protein are specialized protein that is called ion channel, like sodium channel. What is it? It's a protein, specialized protein. It is peeping between the lipid membrane of the above and below, and through that sodium can go in. So that is your sodium channel. So now sodium channel means a protein, and these proteins are being manufactured at the cell body. Remember, all proteins are basically recycled. It is broken down by the proteolytic enzyme and again taken up by the cell body, and again the synthesized there and then going to the periphery via the axons and dendrites. So now if you are ablating the nerve, what is happening? So these chemicals, while going to the periphery, they'll be obstructed at the cut end or damaged end. And this abnormal accumulations of the sodium channel at the damaged end is responsible for the ectopic signal generation. So these two mechanisms, one is crosstalk, another is ectopic signal generation, together is responsible for condition which is called deafferences pain. So what is the deafferences pain? Deafferences pain is a condition where the area is numb. Say for example, my hand is numb, but I am feeling pain from here because of these two mechanisms. One is your ectopic signal generation at the end where my nerve is damaged, number one. And number two is there is a faulty regenerations and there is a crosstalk, and that can cause the different kind of pain, neuropathic pain. So remember these two things, that these are more common with chemical neurolysis. So chemical neurolysis is might be producing what is a condition called deafferentation pain. So we was discussing about what are the different ways to do the neurolysis. Number one is surgery. I told you it was old, but now endoscopic surgery is again gaining the popularity. Second is chemical. 4 chemicals we discussed: alcohol, phenol, glycerol, and hypertonic saline. Then comes is your radio frequency. We are applying heat to produce the lesion. Then your cryo. We are applying the cold to produce the lichen. And sometimes you are compressing the nerve, like the balloon compression in the ganglion ganglion. What we are doing? We are inflating a balloon. We are compressing the ganglion ganglion against the bone in the Meckel scale. And we are compressing, we are denervating that, we are ablating that ganglion. So these are the different ways by which we can do a neurolysis. But out of all those things, most popular is your radio frequency ablation. And then the newer one, cryoneurolysis, is again gaining popularity. It's the most modern way to do the neurolysis. Chemical neurolysis is less popular because the reason I told you, it is the more chance of the deafferences and pain, and because of the chances of spillage to the nearby structures can cause the very serious side effects. And that is the reason why, except for the 2-3 conditions like celiac plexus block, superior half gastric plexus block, the chemical neurolysis are not preferred nowadays, not indicated also nowadays. Okay, so this is very important about the neurolysis. And advantage and the disadvantage, I already discussed all those things. Now deafferences and pain I told, this is because of the crosstalk and the ectopic signal generation. And now I'll be coming about the radio frequency. And to know the radio frequency, we should know about the basic principles of the electricity. So few terms will be very commonly we'll be discussing. One of them is the Hertz frequency. So frequency of electricity means, so how many times? So first of all, you should know that there is a direct current and alternating current. What is direct current? So you are having 2 electrodes. So current is passing from one electrode to the other continuously in the same direction. That is your direct current. And what is alternating current? The polarity is changing. Current going from once from this side, again from this side. So this to and fro is called alternating current. So alternating current is nowadays, almost all household current and domestic currents are your alternating current. But most of the machineries what we are using are direct current. So there should be converted, alternating current must be converted into the direct current for many of these instruments to be getting operated. So alternating current means, again, it is changing its polarity. And how many times it is changing its polarity? That is called frequency, Hertz. Each alternating current must be having a frequency. What is the frequency, or how many number of times it is changing? And in the household electricity, domestic current, what is the frequency? Normally it is 50 Hertz electricity. That means it is changing its direction 50 times per second, right? Now another important term what we are using is voltage. So what is voltage? Voltage is the potential difference between the two ends. So current is flowing from one end to the another. So one end potential difference is higher, one is lower. So it will be flowing in that direction. So that is the voltage. Or in other way, it is compared with the water flowing through a pipe. So in which direction water will be flowing? The high pressure to the low pressure water will be flowing. So this pressure difference from one end of the pipe to the another end of the pipe, this is called the voltage, or difference of the electrical potential, electrical power difference between the two ends. That is your voltage. Ampere is the unit of the current, how it is flowing. The number of electrons are flowing to a particular point at which speed, that is your ampere. So ampere and voltage are directly proportional. That means if you are increasing the voltage, ampere will be also increased. And wattage, what is the power of the electricity? Power of the electricity is multiplication of the voltage and ampere. That is your power of the electricity. That means if you are scoring what is the strength, what is the destruction power of the electricity, how much heat it can produce, it depends on the power, it depends on the watt. So when we'll be discussing about the radio frequency machine, we'll be talking this. What is the power? How much power it is generating? More the power, the size of the lesion will be larger. Okay, so you can understand frequency, Hertz, voltage, potential difference, ampere, flow of current, and your watt, That means it is the power of the electricity. Now come to the next slide. So what is the principle of radio frequency? So as we told, a radio frequency machine is a machine whose input current is domestic current. Domestic current means what is the electricity, what is the frequency? 50 hertz. And output current is how much? It is approximately 300,000 hertz. So 50 hertz input current, output current is 300,000 hertz. So why this is called radio frequency? Because this frequency is basically in the same frequency band with which the radio wave is transmitted. So you are hearing a transistor radio. So the frequency band is similar to that. And that is why this procedure is called radio frequency procedure. Sometimes some make this confusion. Why it is called radio frequency? Maybe like when the radio, what you are listening. Somebody somewhere it is transmitted and I am having a transmitter, though no physical connection, it is a distant kind of things. So probably that is the reason why it is called radio frequency, but it is absolutely wrong. There must be a physical connection. Without physical connections, you cannot have a radio frequency listen. So why it is called radio frequency? Because the frequency of this electrical current, alternating current, is similar of that of the frequency of a radio wave transmission. And that is why it is called radio frequency. So again, just let me tell me what is radio frequency. 50 hertz input current and output current is your 300,000 hertz. So now what is happening? We are putting an electrode. How it will be circuit will be completed? There must be 2 electrodes, otherwise circuit will not be completed. So normally when you are using the monopolar radio frequency, there will be one needle electrode. Needle electrode means a cannula through which you are putting a radio frequency probe, and there will be ground plate just like a diathermy. Here the power of the electricity will be dispersed in the wider area, so there will be no lesion. But circuit will be completed. And the cannula through which we are putting the needle, the probe is a gauge of somewhere between the 14 gauge to 22 gauge, depending on what kind of gauge you are used to take. Okay, so this is a schematic diagram. So here, this is the radio frequency machine. So input current frequency is 50 hertz, output current frequency is 300,000 hertz. And how the circuit is completed? So here is a cannula. It's just like a needle through which you are putting a very fine wire or probe, radio frequency probe, which is of 27 gauge. You are putting it through that needle, and then circuit will be completed through the body, because the body is having the ions, which can transmit the current. But here there will be no lesion. Why? Because it is in a wider area. So whatever the electricity is, power is there, the power will be dispersed in a wider area and there will be no lesion. So lesion will be only here around the exposed tip. So this is like an insulated needle, and tip is exposed where the lesion will be produced. Now, the radio frequency probe itself is not heated, because this is also very important thing to remember. Why there will be lesion? So when you are putting a current of 300,000 hertz, what will happen? Your charged ion will start moving in the same frequency with which your alternating current frequency. That means 300,000 hertz. So it will be moving or oscillating at that speed. So what will happen? It will produce a friction between the non-charged ion or oppositely charged ion, and that is going to produce heat. So this movement power is dependent on the power of the electricity. That means how much is the wattage? With that it depends. More you are going away from the electrode, the power of the electricity will be reduced and there will be no lesion. So the lesion will be in the conventional radio frequency. The lesion will be in the area of the 2 to 4 millimeter. But I'll be coming to the cool radio frequency. In the cool radio frequency, you can increase it by increasing the power. The cool radio frequency power is more, and you can have a larger size lesion. Beyond that area, 2 to 4 millimeter, beyond 2 to 4 millimeter area, the electrical charge power will be dispersed and there will be no lesion produced. And these heat lesions, normally in a conventional radio frequency, you are setting the temperature at 65 to 90 degrees. So now the very important question is how the tip temperature is controlled. That means we are talking that for the conventional radio frequency, you are keeping the temperature of 65 to 90 degrees Celsius. So how we are keeping this Celsius? Because time will pass and temperature will go on increasing. but it is not really show. Temperature is not increasing. When you are after a time, it is remaining same. How? By reduction of the wattage. So what happens when you are giving the electricity, the power? This is denoting the power. So once you are attaining, suppose you are setting the temperature as 80 degree, and your needle, the radio frequency the probe, the thermocouple, that will be sensing the temperature, giving the feedback to the machine that okay, my tip temperature is 80 degree. So now the machine, what will do? It will keep the 80 degree constant, and to do that, what the machine to do? The machine need to reduce the current power. So wattage will be gradually reduced to keep the tip temperature at the same level, and then the temperature also will start falling down. So if it is coming to 78 to 79, then again the power will start increasing, and again it will be going on. That means there will be up and down in the wattage to keep the tip temperature at a constant level. So this is the very, very important concept to understand. So in a conventional radio frequency, the tip temperature is kept at a constant level by fluctuation of the power of the electricity. Once we are attaining the desired temperature, the power of the electricity will start falling to keep the temperature at a constant level. Understand? And what we are compromising? Because we are reducing the power, the size of the lesion. I told you, the size of the lesion is directly proportionate to the power of the electricity. If the power of the electricity is more, if you're delivering the power of the at a higher power, you can have a high size of the lesion. But if your power is less, then you'll be having a small size lesion. So in the conventional radio frequency, because the power starts reducing as soon as you are attaining the temperature of the desired temperature, the size of the lesion is small. It is somewhere between 2 to 4 millimeter around the tip, right? But here the frequency of the current is remaining same. That means current is given continuously. Only thing, frequency is same, 300,000 hertz. Only thing what is fluctuating is your power of the electricity, that is wattage. What will be reduced when the tip temperature is attained at a certain level. So this is your conventional radio frequency. But there is another mean by which you can keep the temperature at lower level. What is that? That is called pulsed radio frequency. So what we are doing in the pulsed radio frequency? We are giving at a, the 300,000 hertz at a certain power. Then we are stopping the electricity. There is a complete silence. Then again we are giving it. Then again you are complete silence. Then again you are giving. So if you are giving this, applying this high frequency 300,000 hertz electricity at a certain power, then that is called pulsed radio frequency. Here there will be no listen. Why? Because temperature is not attaining that higher level. Why? Because we are giving a long silence. And this is called pulsed radio frequency. Now the question is, then how it is effective? What is the benefits if you are giving at that level and that way? The benefit is, by that you can produce a strong electromagnetic field. That strong electromagnetic field is because of the high frequency electricity, 300,000 hertz. But temperature is not allowed to go beyond 42 degrees centigrade. So pulsed radio frequency do not have any ablation or neurolysis effect, because your tip temperature is not going beyond 42 degrees centigrade. Then how the benefits are coming? Benefits are because of strong electromagnetic field that is produced at the tip of the electricity, and because that is because of the high frequency 300,000 hertz. So now to understand the pulse radio frequency, we have to understand the two important parameters. That means how many times you are giving this pulse per second. So 1 second means 1000 millisecond. So normally it is 2 hertz. That means 2 times we are giving the high frequency electricity, and rest of the times is your silence. And 20 milliseconds. This 2 hertz 20 milliseconds is a standard, but you can change it. You can make it 5 hertz 10 milliseconds, or 10 hertz 20 milliseconds. It's depending on parameters and combination, you can change it. But the best effect are observed if you are giving it in 2 hertz 20 milliseconds. 2 hertz 20 milliseconds means you are giving current, high frequency current 2 times, and each time you are giving a current of 20 millisecond duration. That means if you are having 2 times, means 2 cycle, each cycle is of 500 millisecond. Out of that 500 millisecond, you are having 20 millisecond active current. So what is the silence? Silence will be 480 millisecond. That means 2 hertz 20 millisecond pulse radio frequency means 20 millisecond active current, 480 millisecond silence, then again 20 millisecond active current, then again 480 millisecond silence. In that way it is going on. And what happens? Here there will be strong electromagnetic field which might be having the clinical effect. It is not going to abrogate anything. It will having the effect because of the strong electromagnetic field generated at the tip of the radio frequency needle. So see this is taken from the Gauss's book. So here it is conventional radio frequency. The size of the lesion is maximum around the shaft. This part is insulated, so shaft. Tip, we don't have any lesion, and this size is around 2 to 4 millimeter. But when you are applying the pulse radio frequency, the strongest electromagnetic field effects are seen in the tip of the needle. That means why you should know this. So for this, we need to place the needle parallel, not completely parallel, as possible, like that. If you are putting the needle like this, then there will be chances of failure, because in the tip, the lesion is very small size. But here, you can put it perpendicular. That means if the nerve is going like that, your needle can be in this direction. But here, if you are putting perpendicular, the failure will be very much common. So here you should put the needle like this, more or less parallel. Complete parallel is not possible, more or less parallel. Okay, so this is the difference between the pulse radio frequency and conventional radio frequency. How to put the needle? One is your thermal ablation, 80 degree, 65 to 90 degree. Another is no thermal ablation. It is because of the strong electromagnetic field. Now, if you are asking me the question, why strong electromagnetic field is going to have some analgesic effect? Again, it is still not clearly understood. But few hypotheses are there. What are those? That it is going to stimulate some of the analgesic chemicals in the body. That means those analgesic chemicals. What are those analgesic chemicals? These are certain interleukins. You might be knowing there are some interleukins are analgesic, inflammatory, and some interleukins are anti-inflammatory. And it has been seen some of the anti-inflammatory interleukins levels are increasing, and that might be because there we don't know what are the other is responsible for the pulse radio frequency analgesic effect. So analgesic effect is mostly because of this. This means this strong electromagnetic field effect, and other further finer mechanisms still not understood. One mechanism might be rise of the anti-inflammatory interleukins inside the body. Now, conventional versus pulsed. Conventional is giving the better pain relief, higher success, longer pain relief, whereas pulse radio frequency having a very high failure rate. For smaller duration, conventional radio frequency can be giving the 2 to 4 years of pain relief, but pulse radio frequency normally gives something around 4 months to 24 months pain relief. So smaller duration of pain relief and higher failure rate is higher, and the indications are very few. But there is one very important aspect, sir, advantage also. What are the advantage? One is it is safer. Why it is safer? Because you are not ablating anything. Even if there is nearby, there are important structures, you are least bothered, because you are not going to damage anything, because there is temperature is not beyond the 42 degree. And second is because you are not damaging anything, so there is no chance of deafferences and pain. I told you just now what is deafferences and pain. So deafferences and pain is not possible in the pulse radio frequency. So these are the two important advantage of pulse radio frequency, which are the disadvantage of the conventional radio frequency. So the conventional radio frequency might be riskier. Why? Because if you are by chance you are putting your knee close to some motor now, then only motor paralysis, or there is a possibility of the deafferences and pain as well. So these are the other important differences. So pain relief is longer here, pain relief is smaller here. Now the third kind of radio frequency is cooled radio frequency. So what I told at the beginning, that how we are controlling the tip temperature by change of the wattage, change of power of the electricity. And by that what we are compromising? We are compromising the size of the lesion. In the cool rate frequency, our controlling the tip temperature is different. What is that? So the cool rate frequency, there is a channel inside the needle, and through that there is a circulating water. So water is flowing through the tip and taking away the heat. So the tip temperature here is controlled by circulating air, not by reduction of power of the electricity. That means you can still deliver your current at a higher power. Higher power means larger size of the lesion, spherical size of the lesion. So this is the advantage of the cool rate frequency. That means in the cool rate frequency, you will be having a large size lesion, and that will be giving benefits that it can be, easily catch the nerve. The nerve will not be missed. And also, because it will be producing a spherical size lesion, you can put the needle perpendicular to the nerve. Perpendicular to the nerve needle placement is always easy. You can go perpendicular. But parallel to the nerve needle placement is always difficult. Needs a lot of skill and experience. But perpendicular is easier. So these are the advantages of the cool rate frequency. Most important advantage is it is having a very large size lesion. So missing out some of the nerves possibility is less. Now, another kind of radio frequency, the fourth kind of radio frequency is bipolar radio frequency. So what is happening here? Instead of this ground pad, you are having another needle, and it is circulating between these two. We'll be demonstrating at the end of today's class that what is bipolar, what is monopolar, all those things. So it will be going between these two. So what will happen? Both are basically acting as an active electrode, and it will be passing between that, and that will going to produce. So two lesions simultaneously they'll be joined, and that will be having a larger size lesion. But disadvantage is beyond tip you don't have a lesion, and here this part is not having any function here. So this is your bipolar. Electricity is moving between these two. But another very important mode is here, the multi-channel RF. That means, what is the difference between sometimes multi-channel is two electrodes, some are 4 electrodes. So what is that? So here your current is passing between this and this and this and this. So here both are producing separate distance like bipolar, but here the current is not passing between these two. Current will passing between these two. Okay, so bipolar and multi-channel dual mode is almost similar, but mechanism wise it is different. Mechanism wise here it is going circulating between these two. So now why it is important? Why it is multi-channel is better than the bipolar? Why? Because here when you are having the bipolar, one will be basically having a smaller size lesion, another will be having the larger size lesion. That means power of the electricity will be one will be higher, another will be less. But here, when you are using the multi-channel, both will be having the larger size lesion. So bipolar versus multi-channel is better than the bipolar because there both will be having the larger size lesion simultaneously. We'll be showing you on the demonstrating on the machine. Now, to have the larger size lesion, there are different other modalities. I'll be coming to that, but these are the different gauges. So, so this is starting from the 14 gauge to 22 gauge. And you see the diameter 14 gauge means 1.63 millimeter and 22 gauge means 0.64 millimeter. That means to increase the size of the lesion, you can take a larger gauge needle. You can increase the size by 1 millimeter by taking a large gauge needle. But again, large gauge needle means it is more discomfort to the patient. But still, that is another option. If you wish to have a large size lesion, you can take a large gauge needle. Now, there are newer cannulas. One of them is protruding cannula. Means this is the needle and through which another protruding part is there. So that there will be larger size lesion. Cool rate frequency already we told that it's going to produce a spherical large size lesion and monopolar lesion. And it has been seen if you are measuring the diameter, then even with the protruding electrode, it is not comparable with the cool rate frequency. Cool rate frequency, the diameter of the lesion is maximum, and maximum this part also. That means beyond the tip of the needle, here and here, the lesion is very small, but beyond the tip of the needle, this is very large. What is the advantage? You can put the needle perpendicular. Apart from this protruding cannula, there is a venom cannula, so it will bifurcating, or even the trident cannula, which will be basically, having the three important, the trifurcate. It will bifurcate, it will trifurcate. So that can also be having the larger size lesion, but again, none is comparable with the cooled radiofrequency. Cooled radiofrequency, the study says the cooled radiofrequency gives the largest size of the lesion. So there are the different cannula and different shape of the lesion. For the cooled radiofrequency, you will be having a very large. This is for the pulse radiofrequency. This is for the conventional one. This is for the protruding cannula, and this is for the bipolar. But bipolar can give a large size lesion. Bipolar and the cooled radiofrequency are comparable. To increase the size of the lesion, another very important option is increasing the time. If you're increasing the time, then also there might be a larger size lesion. And this is the relation with the lesion size with the time. So if you're going into the time, when you're increasing the time, gradually it will be increasing, but it will be coming to a plateau. That means after 60 seconds, still there will be size of the lesion increasing, but at a very nominal rate. And that is the reason why most of the time it is unnecessary to go beyond 2 minutes, 120 seconds, or maximum in the cooled radiofrequency, we go for a 2.5 minute lesion. After that, the size of the lesion is not going to increase. Then it will be going almost parallel to the time. Even if you are increasing the time, the size of the lesion will not be increasing. So initially it is, more you are increasing the time, more the size increasing, then we gradually come to a plateau, and then it runs parallel almost. After particularly 2.5 minutes, there will be no increase in the size of the lesion. So what are the ways to increase the size of the lesion? Number one is, simplest is your increase the gauge of the needle, increase the time up to a limit, not nicely. Use the cooled radiofrequency, very important way. Use the bipolar radiofrequency, very important way. Or using the newer cannula, like protruding cannula, venom cannula, trident cannula. These are all by which you can increase the size of the lesion. So before putting, another very important thing is, before you are putting the needle, you must be confirming that your needle is placed nicely. So how to know that? One is by image guidance. Either you have to place the needle under the USG image or CRM image. And second is, you can stimulate the needle. Stimulate the needle and you should get the sensory stimulation or motor stimulation. One very simple rule to remember, that the frequency you are increasing, it is the smaller diameter fiber will be more stimulated. That means when your frequency is very less, 1 to 2 hertz, motor fibers will be more stimulated. And if you're increasing more, like 50 to 100, then your pain fibers will be stimulated. To stimulate the touch fibers, normally between 20 to 40 hertz is the electricity. So to stimulate the sensory fibers, particularly the pain fibers, 50 to 100 hertz, and motor testing to see the contraction. So all this, you have to understand that you are close to your target nerve and you are away from nearby nerves. That is also very important. That your needle is sometimes placed in such a way that you are close to your target nerve, but your needle tip is also close to your nerve, which is not your target, which is dangerous. Suppose you are putting a long cannula in the medial nerve block, and your needle is going closer to your nerve root. What will happen? You'll be doing successfully the medial branch block, but at the same time, you might be updating the nerve root also. So you have to do the motor testing for both the things, whether you are close to other nearby nerve. That is also very important. So both sensory testing, motor testing, image guidance, all together, you have to be sure that you are close to the nerve, and then only you can go for the listening. Indication, there's a long list of lesion. Go with this. Pulse radiofrequency, there's the indication. Cooled radiofrequency, there's the indication. Cooled radiofrequency means where there is no nearby structures. You can have a large lesion and you can have a sure that you are going to ablate the nerves. There are the bipolar radiofrequency lesions. So there are the different indications. Read it nicely. I'm not discussing now. So thank you very much. Any questions regarding the radiofrequency, you can ask me. And then Dr. Chinmay will be talking about the pharmacotherapy. And then I'll be talking about the cryoneurolysis. And at last, we'll be demonstrating the machines. So any questions regarding radiofrequency right now?
Hello, sir. Question, sir.
Yes.
Is there one machine interchangeable? One machine can use for conventional, change to power, change to cool, that or no, or different machine?
Okay. So cooled radiofrequency machine they can be used in all purpose. Means you can use it for the bipolar, monopolar, your pulse radio frequency, everything. But the other machines, other brand, there are different companies, no? So cool radio frequency companies have the all modes. But other companies like today what we'll be discussing, it don't have the cooled mode, but it can be done bipolar, multi-channel, pulse radio frequency, other things can be done. That means coming back to your answer to your question, it depends on the companies, which company's machine you are using, whether you are able to use all the different modes in one machine or not. Okay,
Like Cosman, sir. Cosman.
Cosman, you cannot use the cooled mode, is not there. But in the Cosman radio frequency, you are having the conventional bipolar, cooled, so not cooled, sorry, pulsed, all these modes are there. And also Cosman newer model are there. Cosman, not one model. Cosman, there are 2-3 types of models are there. The highest version of the Cosman model, you can have the multi-channel, 4 listen, you can do it simultaneously in the Cosman machine. That is of the higher version. But the basic version of the Cosman machine, you don't have the option for the multi-channel RF, but still you can do the bipolar radio frequency and you can do the pulsed and monopolar. Okay.
Thank you, sir.
Sir, I have one question, sir.
Yes.
Sir, the neuromodulatory effect of pulse radio frequency, which you have explained, is it specific to only pulse radio frequency, or we can see the same effect with other mode of radio frequency?
You see, why there is, it is a very intelligent question. Why we are having the electromagnetic field? Electromagnetic field is because of what I told?
Sir, pulsed wave, due to pulsed wave.
No. It is because of the frequency of the electricity. When you are delivering the electricity, alternating electricity at a very high frequency, that means 300,000 hertz, you are generating a strong electromagnetic field, right? So that is the mechanism. That means if you are using the conventional frequency, there will be also electromagnetic field generation, isn't it? Understand? That means electromagnetic field effect is also there in all kind of radio frequency. But what happens when you are ablating a nerve, this nerve ablation effect is so dramatic that the other effect is not profound. That means pendulum will be there and then there will be nerve ablation is also there. So both are simultaneously there. Pulse radio frequency only analgesia, but here the effect is so dramatic that the other immunomodulatory effect is what I should say, it should be under the shadow of the ablation of the nerves. Am I clear?
Yes, sir. Yes, sir. And sir, one more question. In continuous mode or cooled mode, when we are ablating one nerve, what structural changes is there? I mean, how can they regenerate? If we are ablating them, then how can they regenerate? If there is charring and
I'll be answering this question when I'll be talking about the regeneration of the nerves. Okay. In my next class, I'll be discussing that what are the possibilities when the nerve can regenerate and when the nerve cannot regenerate. Okay.
Thank you, sir.
Okay.
Could you please explain again how the tip temperature is controlled, sir?
So in tip temperature control by conventional mode or cooled mode, which one you are asking?
Conventional RF, sir.
So what is happening? We are putting the needle and the needle is made up of thermocouple. So that will be sensing the temperature and giving the feedback to the machine that, okay, my set temperature was 80 degree. Now 80 degree has attained. So now what machine will do? Will keep the temperature at 80 degree. How to keep it? To reduce the wattage. At the beginning, I told the size of the listen depends on the wattage or power of the electricity. So power of the electricity will start reducing. And that is how the tip temperature is being controlled. That means once you are attaining that desired temperature, the power of the electricity will start reducing and the temperature will be kept at a constant level. Now, if you are, the temperature is again coming down too low, then again power will go up and will be keeping it temperature at the same level. That means power of the electricity will be fluctuating to keep the temperature at constant level, right? But for the cool radio frequency, it is not. Cool radio frequency, how? By circulating water inside the needle, that is going to take care of the temperature control. And for that, you are able to deliver the current at a higher wattage, higher power. and that is going to create a larger size lesion in the cooled RF.
Thank
Clear?
you.
Sir, sir, can you please repeat the advantage and disadvantage of bipolar frequency, sir?
Bipolar radio frequency advantage is you are putting two electrode. One of the very important advantages, if you are having somebody is having the pacemaker, then you should use the bipolar one, because electricity will be limited to that between the two poles. It is coming to have the larger size lesion because you are having individual lesion between this needle and another needle. But disadvantage is it is a conventional radio frequency. That means beyond the tip of the needle, there will be no lesion. That means your needle should be placed very close to the nerve, parallel to the nerve, not perpendicular to the nerve. Because perpendicular to the nerve, beyond the tip, you don't have any lesion. So this is the disadvantage.
Yes, sir. Thank you, sir.
Okay. So Chinmay, can you start your any other questions? Quick, one or two quick questions. Otherwise, already you are late. Chinmay will be starting the class. Chinmay, are you ready?
Yes, sir, I am ready.
Okay, you will start.
Surrounding. Okay. One or two questions were there. Okay. Okay. Let me start. Yeah.
Okay.
Okay. So today my class is about pharmacology of pain pharmacology. Okay. So thing is that it is a very big, I mean, like huge chapter, and if I want to go elaborate, then it will take a whole day. So I will say only the specific I mean, like important things which we use in our pain practice, and just a few lines so that you can remember that and understand that what I want to say, and then the rest of the thing you read from the book. So here you see, say a nociceptive pain. This slide is of physiology, of course, and physiology and pharmacology is, I mean, at least in this scenario, it is, I mean, like accompanied together. Okay, so here it is a noxious stimuli, and this noxious stimuli will cause some cytokines will be released here, and ultimately one action potential will develop here. Then first order neuron, this action potential will travel to the dorsal horn, and then it will the second order neuron from the I mean, like your dorsal horn of the spinal cord. From there, second order neuron will start, and it will take the pain signal. It will take the pain signal, and then it will reach to our thalamus and then upper sensory centers. Okay, so in this way we will we usually receive the pain signal. So here there are for any pain, in the peripheral pain, there this spinothalamic tract is in action. And say if we want to talk about the trigeminal pain of the facial pain, then there is also the same thing. I mean, trigeminal nerve, this A delta and C fiber, they carry the pain, and ultimately we perceive the pain at our brain. So now there are some central connections. I mean, in central connections, this perception part is it has okay, I show you this one first. Okay, so here one thing, this in pain pathway, it can be it has three main parts. One part is the transduction. When the electrical activity was first started from a chemical reaction, when there was an injury, so the chemicals were released and then electrical activity started. So this was the transduction area. Okay, this is the transduction area. And when the pain signal transmitted, gradually the transmission of this thing with the pain signal, first order or second order neuron. So this is the second part of pain pathway. This is called transmission. And then third part is your perception. Third part is perception, when we perceive the pain signal. So mainly three parts. One is transduction, then transmission, and then third part is perception. Another part is there, that is modulation. So this is also the fourth part, that is the modulation. This modulation is there in the physiological state also, and it can be pathological also. In physiological stage, this modulation decreases the pain perception, and when it is in pathological stage, this descending modulation, this stops working, and either stops working or it works in such a way that pain is generated more at the DRG level, that we call sensitization. So ultimately together they are 4 parts: transduction, transmission, perception, and then modulation. So here, as I told you, whether it is your sensory I mean like pain from the periphery or facial pain, this way the pathway continues. But then central connection, what I want to say, this perception part, this perception has 2 parts. One is emotional affective and another is sensory discriminative. Means one part which is actually dependent on sensory stimulation only, and another part is emotional part of the patient, and both together actually affect the perception part. So it can happen that the same pain, I mean like for an example, that if some player is playing football and he got an injury, and then he fell down on the ground, and immediately he woke up and again he started running. After the game was over, or after a few minutes, he understood that okay, his joint is broken, or I mean like bone is broken. This happens. So why? Because it is not only the sensory discriminative part, it is not only the sensory part which decides the perception part, it is the emotional component also which decides the perception part. These 2 things. Okay, so we understand these connections. You later see prefrontal cortex, anterior cingulus, this one, SAC, insula. So these areas are responsible for emotional component, and sensory 1 and sensory 2, I mean these sensory nucleuses are there for the sensory component. So the summary is that for perception it has 2 parts. Okay. Now, for treatment purpose, this I will tell later. So, for treatment purpose, we can, as we are treating the, I'm talking about the pain treatment by pharmacotherapy. So, pharmacotherapy, we can target all these 4 parts actually. So, if I am targeting the transduction part, then it means that I want that electric stimulation from the chemical which is released at the site. From this chemical to electrical stimulation conversion, there only I am attacking. I am targeting to treat the pain there. So NSAID will treat the pain at the transduction level. If I am targeting the transmission level, then actually local anesthetic or other anti-epileptics, opioids, mainly opioid, local anesthetic, these are all transduction level. The pain signal will not cross the dorsal horn area. Dorsal horn area, it will not cross. I mean, it will cross, but in a dampened way. So this dampening will be caused by these drugs. Okay, local anesthetic will totally block, and other anti-epileptics, opioids, those things, many other drugs are there. So those will actually dampen the transmission. Okay, so this is the if we want to target the transmission part, then these are our drugs. Then comes modulation. If modulation we have to increase, that we want that descending modulation, which usually dampens the pain perception, pain signal. We want that descending modulation to increase its work. It should dampen more. So in that case, we will use these drugs, antidepressants, mainly antidepressants, and then other spinal cord stimulation also. These are not pharmacotherapy. So antidepressants are main drugs which will act at the modulation part of the pain pathway. Okay, and then comes perception. So in perception, as I told, it is a two pathway. One is sensory discriminative and emotional affective. So if I mean in sensory discriminative pathway, these drugs can be used, and in perception part, this cognitive behavioral therapy to we can target the emotional part. Okay. So while taking the history, always we are taking we want to think that what is the pain generator and what is the background phenomenon. I mean, say a patient with back pain has come, you want to know that if the pain is coming from SI joint, facet joint, whatever, and then background phenomena, why that joint has is producing pain. So it may be inflammatory, it may be infective, degenerative. Most of the time, in our case, it is degenerative. But then this type of all these phenomena can occur. Any type of phenomena can occur, which is causing the pain generator to cause pain. So if we simplify this type of all the type of phenomena together, then we will get one is nociceptive type of pain and one is neuropathic or nociplastic. Nowadays, these two pains are separated, neuropathic and nociplastic, but otherwise treatment remains same. So we will consider one treatment approach for nociceptive pain, one treatment approach for neuropathic pain. And psychogenic pain, I will not discuss here, but psychogenic pain, cognitive behavioral therapy, if there is a psychological component, if you suspect. So mainly, let us see pharmacological our approach towards a nociceptive pain and neuropathic pain. So ultimately, you understood that if a patient comes with pain, we will first think what is the pain generator. Second thing, what is the background phenomena, and when we think that what are the background phenomena can happen, then we will think that what is the type of pain which is involved in that type of background phenomena. Either it is causing nociceptive pain or neuropathic pain or mixed pain. Okay. So if it is a nociceptive pain, then what happens? Then we can target the NSAID with NSAID, the transduction part. Okay. If we want to target the transmission part, then mainly opioid causes the transmission part. We can attack with local anesthetic also. In transmission part, we can attack this nociceptive pain in spinothalamic pathway, I am saying. And paracetamol, though we don't know the exact way of working of the paracetamol after 100 years of its use also, we don't know how paracetamol works, but still it also has some action in the transduction and mainly transduction part. So these were the nociceptive pain. In neuropathic pain, what happens? So in neuropathic pain, it is not a simple pain which is coming from the periphery to the center in our head. It is in nociceptive pain starts from periphery and goes to the our thalamus, upper cerebral cortex, so whatever, that is the nociceptive pain pathway. But in neuropathic pain, what happens? You have to understand that in nociceptive pain, pain is transmitted by the neural pathway, but as such, the neural pathway does not produce the pain. Okay, it doesn't change anything. Whatever pain signal was coming from one end, it will produce the same signal to other end. That is nociceptive pain. And in neuropathic pain, the main pathway gets disturbed. So it gets little amount of pain, but it produces much more amount of pain. So it has its own input there. So that is the neuropathic pain. The main earlier our nerve was used for transmitting pain. In neuropathic pain, is nerve is producing pain. Okay, so this is the neuropathic pain. So in neuropathic pain, we will treat mainly the modulation part. We can transmission also, and modulation part, mainly modulation. So anticonvulsants, these have the effect of modulation. Modulation means what? Modulation means normal modulation is also going on through our descending inhibitory pathway, which is actually dampening the pain signal. So if we use these drugs, anticonvulsant, antidepressant, NMDA receptor antagonist, so all these drugs together, what they will cause, they will dampen the pain even more from first order neuron to second order, go to second order neuron. So these are the main drugs for neuropathic pain. Anticonvulsants means our pregabalin and gabapentin. These are main anticonvulsant drugs, but we use carbamazepine also as in trigeminal neuralgia, oxcarbamazepine also as in trigeminal neuralgia, or topiramate as in migraine. So these are anticonvulsants. Antidepressant may be of different types like MAO inhibitor, SSRI, SNRI. So different anticonvulsants are there. But for us, it is the tricyclic antidepressants. Mostly we use for neuropathic pain, for modulating, targeting the pain pathway in modulation part. So what are our antidepressants? Tricyclic antidepressants, that is amitriptyline, nortriptyline, okay, and SNRI. SNRI means duloxetine. So mainly these three drugs, even venlafaxine. So these four drugs we are using as for pain. It is not that all antidepressants work in treatment of pain. Only these 3-4 drugs are there which we use for control of pain, which have evidences. So amitriptyline, nortriptyline, and duloxetine. Okay, venlafaxine also you can use. So NMDA receptor antagonist. NMDA receptor antagonist is also has been shown to act against neuropathic pain. What it does, as I told you, that nerve becomes diseased. It doesn't only transmit, it causes, gives its own input, and it causes more pain. So NMDA receptor has been shown to decrease that sensitization part. That is also a type of modulation. So it also acts at modulation. Topical agents, capsaicin, this is again not modulation part. This is in the transduction part. This is in the transduction part. So capsaicin is a topical agent for post-herpetic neuralgia. We can use capsaicin patches. And then steroid is also working in the transduction part, because it acts like your prostaglandin pathway. Okay, alpha 2 agonist, clonidine, dexmedetomidine, those things in mainly in acute pain, but then other creams are there, local topical use creams are there. And then muscle relaxant, these are not directly working pain treatment, but then these are adjuvant drugs, like these are adjuvant drugs. So muscle relaxant, botulinum toxin, they causes relaxation of the muscle, because muscle spasm many times causes the pain. Like botulinum toxin, why we use? Because for migraine, when we consider that pericranial muscles are the cause of headache, so botulinum toxins are used for migraine. Muscle relaxation, sometimes patient will come with acute muscle spasm, even acute back spasm, neck spasm. In those cases, these are adjuvant drugs we use for pain practice. Bisphosphonate in osteoporosis. DMARDs. DMARDs is another drug which is also in the prostaglandin pathway, TNF alpha, TNF inhibitors mainly. So those also in the transduction pathway it work. So this also causes the starting of pain signal. Okay, so these are used in inflammatory arthritis cases. So these are directly not painkillers, but pain practice people, they have to use these drugs also. So now there is a WHO ladder, just to tell you that earlier this is a modified WHO ladder. This is not the original one. Original one had step 1, step 2, step 3, and it was going from down to up, and that was used only for cancer pain. Okay, then it was modified and step 4 has been added. It became bidirectional. If there is a acute pain, then there is no point of starting, and then it became for cancer pain, non-cancer pain both. Then what it says if the pain is very mild, first step is non-opioid analgesic, NSAIDs. Second step, weak opioids, and then strong opioids. weak opioids, what are weak opioids? Tramadol is a weak opioid. Okay, then this strong opioids, and then nerve block, our different procedures. These are step 4. So if a patient has come to you with acute pain, you will see that patient's pain is how much severe, and then if it is an acute pain, you can start from up to down approach. Like first you will give the nerve block, epidural, everything, so that pain goes down immediately. There is no point of experimenting from down to up, that whether it works or not, then we give this, nothing like that. If it is a chronic malignant pain, then mostly this is used, or can non-malignant pain also. If it is chronic, then we will start from step 1, step 2, step 3, like that. Okay, for acute pain from up to down. So this is a whole ladder modified. Okay, so overall pathways. Before that pathway, I show you one. So okay, as I told you that first pain starts in the peripheral neuron, in first order neuron, and then it goes to the second order neuron. So this is a picture of typical synaptic junction, I mean like synapse. So this is a presynaptic neuron, this is a postsynaptic neuron, and this is the synaptic cleft. Okay, so what happens actually? So what happens? Just a minute.
No sound. No sound.
Yeah, I'm not talking actually. I took 1 minute time. So okay, so this is a presynaptic. It is a typical synapse. Okay, so what happens? The presynaptic terminal is like this. This is the postsynaptic, and this is the synaptic cleft. So what happens when the axon, there is an electrical signal. So electrical signal comes like this from the upper side, like this, and then it will hit the synaptic vesicles where the neurotransmitters are located. Then neurotransmitters will come down like this, and it will come to the receptors on the postsynaptic membrane, and then the action potential will and then when the neurotransmitter will attach to this different receptors, transmitter to receptor, and then it will cause entry of the sodium or calcium inside, and then action potential will be transmitted. Okay, so that is the normal pathway. Now there are some excitatory transmitters. So glutamate is one excitatory transmitter. There is another transmitter called substance P, that is also excitatory transmitter, and there are some receptors for this glutamate transmitter. So one receptor is NMDA, another is AMPA. So these type of receptors are there. Okay, so where we can target when we say that we will do the we will stop the transmission, then what we will do? Either we can do we can give some drug so that this receptor is blocked, so that this transmitter cannot come and join to the receptor. So we can do that, or we can do some drug so that this transmitter doesn't secrete anything. This synaptic vesicle do not secrete any transmitter, so that also we can do. Okay, so these two things. Third thing, what we can do? Third thing we can do, that when it opens, it I mean like transmits calcium from either calcium or sodium. So it transmits the one ion from outside to inside. So that one also we can block. That ion will not be available here. That will not pass through. So that way we can stop transmission, or we can do some modulation also. So modulation, what it does in general, modulation they synapse another neuron, which is inhibitory neuron coming from up. They will cause a joined here, they will cause a synapse here in the presynaptic membrane, and then they will secrete some, they will target some, say, opioid receptor. So opioid, there will be opioid receptor, and they will target the opioid receptors. They will stimulate the mu receptor, kappa receptor, those receptors, and then they will do what? They will secrete some I mean, like, what they will do, they will just stop the vesicles to secrete the excitatory neurotransmitters. So those are different ways how we can stop the transmission of the forward going of the action potential. Either we can stop directly or we can modulate, and that also ultimately will cause that will not allow the same signal to pass through the synapse, that will dampen the signal. So that is called modulation. So okay, now that is a I mean, very simplified summary. Okay. Because okay, so here this overall pathways. So how many pathways? There are multiple drugs, so there are multiple pathways also, but then common pathway is prostaglandin pathway inhibition, and then opioid receptor activation, and then NMDA receptor pathway, NMDA receptor, as I showed you now, that NMDA receptor blocker, and that serotonergic pathway. These are reuptake inhibitors. Serotonergic and cannabinoid pathways are newly identified, not very old cannabinoid pathways. Okay, so these are reuptake inhibitors. What they do? So prostaglandin pathway. Let us recollect. This is the cell membrane phospholipids. Phospholipids become arachidonic acid. From arachidonic acid, prostaglandins are secreted. So when we give our local anesthetic, not local anesthetic, NSAIDs, they actually stop here. They don't allow arachidonic acid to form prostaglandin. That is by NSAIDs, which is COX-1 and COX-2 inhibitor. Though our target should have been only COX-2 inhibitor and not COX-1, because COX-1 is physiological. I mean, it produces some useful prostaglandins, but which is the harmful prostaglandins is mainly produced by COX-2. So anyway, this arachidonic acid to prostaglandin pathway is blocked by NSAIDs. Other thing, arachidonic acid, if not acted by, not converted by COX, I mean cyclooxygenase, then lipooxygenase also converts it to leukotrienes. There are also some TNF alpha inhibitors work in this pathway for rheumatoid arthritis and all, that I'm not going into it. So this much you remember, that for from cell membrane phospholipids, arachidonic acid, then prostaglandin. So here NSAIDs act. Opioid pathway, what it does, it is actually, you can see, this is a synapse. So here opioid in the presynaptic membrane, there will be opioid receptors. So when we give opioid, either it is endogenous opioid or exogenous, this opioid receptor will come, opioid will come and act in these opioid receptors. So these receptors are multiple types: mu, kappa, delta. These are known types, and sigma is no more considered as opioid receptor, but then these three types are there. So opioid will come and join here, and which will ultimately cause the this calcium channel, which transmits transmits calcium through this this channel. Through calcium channel, calcium comes out. So this will be stopped by the opioid receptor. So this is a type of modulation. This is a type of modulation, or it is a type of transmission stop also. So ultimately this fiber will stop this action potential from primary fiber to secondary fiber, secondary neuron. It will not go. So this is the opioid pathway. Opioid comes and neurotransmitter from primary neuron is not released if opioid receptors are activated. NMDA receptors. So glutamate, when it is released, they activate the NMDA receptor, and sodium ions enter through this. Okay, sodium ion and calcium ion is entering through this. So here also, if NMDA, we are giving an NMDA blocker, then NMDA blocker will go and it will stop this receptor to give channel for sodium and calcium. So sodium and calcium cannot go. This is a different thing, magnesium. So sodium and calcium cannot enter if NMDA receptor blocks this NMDA channel, receptor. Then NMDA antagonist, if blocks the NMDA receptor, these ions doesn't enter and action potential does not proceed. So what are our NMDA antagonists? Ketamine is a NMDA antagonist. So serotonergic, nonergic pathway. So these are very important for modulation. So here also, these are serotonergic. You have to understand tryptophan. From tryptophan, the 5-HT, this serotonin is formed. Tyrosine, from tyrosine to noradrenaline is formed. Okay, and then when these vesicles secrete them, here they are destroyed by some enzyme. Okay, so those enzymes can be stopped. Those enzymes can be stopped here, so that serotonin concentration is increased, or noradrenaline concentration is increased. And otherwise also serotonin is reuptake inhibitor, means serotonin through these channels, this serotonin is it goes in the primary neuron again. So that is called reuptake. So that reuptake can be blocked. In the same way, noradrenaline reuptake can be blocked. So in the synaptic cleft, serotonin and noradrenaline, your concentration will increase, and that will ultimately increase the inhibitory action, inhibitory pathway of inhibitory modulation. That will increase the inhibitory modulation. So those which are increasing the inhibitory modulation pathway, that is the those drugs are causing mainly the effect on modulation part of the your pain pathway. So this serotonergic and noradrenergic drugs are most important for treating neuropathic pain. So SNRI, duloxetine, and if it is in TCA, if it is noradrenergic, then SNRI is duloxetine, and then TCA, which acts at both the terminals, those are amitriptyline or nortriptyline. Cannabinoids, those also there are from cannabis plant. We get two types of cannabinoid mainly. So one is CBD, one is THC. Mainly CBD is used for a therapeutic use. So it also ultimately acts here in the first order neuron presynaptic terminal, so that here cannabinoid receptor is CB1 receptor always there present. So when it activated, when it is activated by cannabinoid, by CBD, then the glutamate type of activating this one transmitter, excitatory transmitter, does not come out from the vesicle. So ultimately the action potential which is transmitted is dampened. So these are the this is the cannabinoid pathway. Somebody is asking anything? Okay. Somebody is just a minute. Okay, so ultimately, so cannabinoid, there is nothing in the market at present, at least in India, as a treatment purpose, but it may come. So okay, then biopsychosocial and behavioral approach is not a pharmacotherapy. Just to tell you that here also we can decrease the pain perception. If we want to target the pain perception, we have to understand the biopsychosocial approach to pain, and then behavioral approach is required to treat this biopsychosocial concept of pain. NSAID classification. There are many different type of NSAIDs are there. Why it is needed? Because there are different diseases like say spondyloarthropathy. When you are using a acetic acid derivative, say diclofenac, you have given the drug to the patient for 1 month of this one a trial, 1 month of trial, that whether the drug acts or not. So you have given diclofenac to a spondyloarthropathy patient. If the patient doesn't get relief, then next time you cannot give trial with the same group of drug. After diclofenac, you should not start etodolac. You have to search another group of drug. Then you will go to a ibuprofen. This is a propionic acid drug. So this is recommended like this, that in NSAID also, so if one group of drug doesn't work, you have to go to the another group of drugs. So you must know that in classification which drug stands where, and so that you can choose a different group of drug. So NSAID, we know COX-1, COX-2 inhibitors, selective maybe or non-selective maybe. So otherwise, when the prostaglandins are not formed, then transduction area, it is the we are targeting the transduction area, and pain just doesn't start even, or low intensity pain will start. So okay, there is one NNT comparison of many NSAIDs, mainly paracetamol is also there. So this is just for comparison, that how much, which is the most effective drug. So it has been shown that ibuprofen paracetamol combination is most effective, because NNT is the most lowest NNT. Okay, and this was a Cochrane, I have taken from Cochrane review, but this Oxford analgesic league table, this is most widely used. So here also many different drugs has been used, and it has also shown ibuprofen paracetamol combination is the most effective drug for actually for acute pain, nociceptive pain. These are not for neuropathic pain. These are acute nociceptive pain, and it has been evaluated for 50% pain relief for next 4 to 6 hours. Okay, so it doesn't apply everywhere, but then you have to know. Paracetamol, as I said, that after so many 100 years of use also, we don't know where it works, but still inhibition of COX-3 isoenzyme. This is COX-3 isoenzyme in the brain only, and which also causes ultimately inhibition of prostaglandin synthesis. So there are many other like modulates the endogenous cannabinoid system. These are modulation parts. So this is a combination of different actions, combination of different actions. Okay, so why these things are too much important? Because while writing a prescription, if you write the same person pregabalin also, gabapentin also, or I mean 2 different painkillers of acting in the same receptor, then it looks very much foolish prescription. So that's why we should know that where we are targeting, which receptor we are targeting. So in that way, so I will not go in detail. So paracetamol, so we know, and opioids. So opioids, you know, there are opium, opioid, opiate, opioid. There are 3 terminologies. So opium is a mixture of alkaloids that is not needed. That is the from poppy plant we get. Opiate is actually naturally occurring alkaloid. Morphine, narcotin, codeine, thebin, papaverine, nursing. So these are naturally occurring. And opioid, sometimes not natural or synthetic compound, is this is actually wrong. Opioid is synthetic. Opioid is synthetic. Opiate is natural. That's it. So action at receptor level. So as I told, when opioid acts, there are some differences in agonist, antagonist, and antagonist. So ultimately, when ultimately when it acts in the receptor, it decreases the pain signal transmission. Mechanism of action, you will know this through the mu kappa delta receptors, and there are different classifications based on intrinsic activity or based on receptor and based on production. So these are classifications. Potency comparison, opioid potency compared to morphine. Always how much potent, how much efficacious, you can say, that is we understand by we always compare with morphine. So not efficacious, potency. Okay, but all the opioids are have the same efficacy. It is said like that, and potency is different. So 90 times more potent than morphine. It is nearly 100 times. So there are tables, different tables for comparison. So when we treat a cancer pain, say a patient, we are giving morphine for some time. So after few days, he is coming that no, I cannot tolerate more because I am having constipation or some other reason, constipation, so itching also. So then you want it to, but you pain is not relieved, but he is getting constipation. Then you want some other drug which will have less constipation, or I mean, like, you have to change to other drug. Then what will you do? You have to use this chart. Okay, you want to give, say, severe pain for fentanyl patch. You want to give fentanyl patch. Then you have to change to the equivalent dose first, and then of course starting should be half of the equivalent dose, and then gradually increasing it. Okay, so that is one way. So this type of charts you have to keep. Side effects, opioid have many side effects: nausea, vomiting, constipation, sedation. These are all important side effects we get usually, I mean, like, very commonly. Respiratory depression is the most dreaded side effect of opioid use. Always remember, respiratory depression, suddenly one patient does not develop hypoxia. Okay, so first symptom is sedation. First if the opioid is more, the first symptom is sedation, then the respiratory rate, and then hypoxia. So those three things, I mean, like, at least sedation is the first thing to strike your mind that we should decrease the opioid. Okay, so these are the side effects. There are newer preparations are coming, as I told you, that constipation, it is causing constipation. So there are some peripherally acting opioids which doesn't cause constipation. So methyl naltrexone is one of them. So these things are used. There are some abuse deterrent products. Why we should be very much careful? Because in worldwide it has been seen that opioid causes too much of abuse, and even some studies have shown that people causing abuse, their 1/3 is from prescription drugs. So if that is the case, then we should think of using those preparations which doesn't cause abuse. So there are some abuse deterrent products. I mean, these drugs, if one takes more, they will have dysphoria. Okay. Local anesthetic, we know it very well, that sodium channel blocker. So sodium will not come inside, and our ultimately action potential will not go from one synapse to another synapse. Okay, so this is the transmission part. Okay, then comes anticonvulsants. These are also, as I told you, that calcium is also entering through the post synaptic terminals through the receptors. Calcium increase goes inside, and then only action potential transmits. So action potential propagates from periphery to center. So anticonvulsants, gabapentin, pregabalin, these are main drugs. Carbamazepine, oxcarbamazepine, topiramate also we are using for different purposes. But gabapentin and pregabalin are widely used. Always remember, gabapentin doesn't mean it works on GABA. It doesn't work in GABA. It works in calcium channel, alpha 2 delta 1 subunit of voltage gated calcium channel. So gabapentin and pregabalin, they both act at calcium channels. Okay, so and they have many different mode of action. Not only this one, they have action on NMD receptor, also protein kinase C and inflammatory cytokines they reduce. So those things, but mainly it acts on calcium channels. This thing you have to remember. Okay, here it is shown calcium. So GABA, when GABA acts like this, alpha to delta, through this channel only calcium enters in the presynaptic membrane, and it comes through this. So when GABA, this receptor is activated, that calcium doesn't come. Calcium doesn't come and doesn't go there also. So in these two areas, this gabapentin acts. Okay, these are what okay. There are some. I mean, gabapentin is safer than pregabalin. So these are the side effect profile of pregabalin. So there are many side effects of. There are many side effects of pregabalin, though we use because it is less sedative, but then gabapentin has many. Gabapentin is safer than pregabalin. Okay, carbamazepine mode of action, carbamazepine, topiramate, they all actually work through sodium channels. Sodium channels. Ultimately, whatever they do, when if sodium is not passed through the channel or calcium is not passed, ultimately action potential will not propagate. Antidepressants, as I told you, this also increase the serotonin and norepinephrine in the synaptic cleft, which will ultimately cause the inhibitory pathway, I mean, more stronger. So that is the NMDA receptor antagonist. NMDA receptor antagonist also, I mean, like that will be blocked. So action potential will be dampened gradually. And then capsaicin, it acts in the TRPV1 receptor. TRPV1 receptor, this is in the transduction part, first part. Okay, so these I am not going into it. These are other drugs which are not much important. Steroid. Here you see steroid also work in where it does work. This you remember NSAID from arachidonic acid to prostaglandin. There mainly NSAID was using. I mean acting here. Phospholipase A2 to arachidonic acid, just above the NSAID action area, steroid is acting. So this is the area of steroid action. Here also steroid acts something, but mainly it is the formation of arachidonic acid and formation of prostaglandin by NSAID. So other agents, there are many agents are there. I am not going into it. So DMARDs, as I told you. Okay. So okay, thank you. This is only the outline of the just I wanted to tell you what are the drugs we use and mainly where the drugs work. We target which part of the pain pathway, either it is transduction or transmission or modulation or perception. So, and if you read more about, want to read about more about the drugs, I mean, you should read. So those things. If you have any question, you can ask me. Okay, someone has asked fibromyalgia and CRPS type 1. What type of pain? this is pure neuropathic pain. CRPS1 is the pure neuropathic pain. In fibromyalgia, someone can say that okay, neuropathic pain is also there, and some amount of psychogenic pain also can be there, because in general the fibromyalgia patients are very much anxious, and sometimes they have some personality disorders also. It is possible. So but then CRPS is completely neuropathic pain. Yes, nociplastic pain now, as per the newer classification, because they have divided neuropathic as typically those pain where you can see, you can reproduce that which nerve is damaged. But in these cases where typically the nerve we cannot find, that is nociplastic. Okay, how to write prescription for neuropathic pain like disc pain? Okay. Type of pain. Another way, does ketamine helpful in non-neuropathic chronic pain condition? See, ketamine, you all know it is a dissociative anesthetic, isn't it? So if you prescribe someone ketamine, he has to be within the hospital, otherwise patient will cause ruckus in outside, no? So it is only we are doing when we are doing systemic desensitization for fibromyalgia patients, severe fibromyalgia patients. Okay, and inside OT for different acute pain you can use, that is different. But in chronic pain we have only single use of ketamine, and that is systemic desensitization of widespread fibromyalgia. Okay, second thing, how to write prescription for neuropathic pain like disc pain? So disc pain, as such, pregabalin, gabapentin you can write if there is a first thing is your pain generator. If pain generator is completely the disc, then this type of I do not see that whether you should give too much of pharmacotherapy. You should depend on too much of pharmacotherapy. Discogenic pain is very difficult to treat, and many drugs has been unsuccessful in treating discogenic pain. But most of the time discogenic pain, disc ultimately doesn't cause the pain. Disc causes compression of the nerve and patient is having radicular pain. In those cases you can use this anti-epileptic, antidepressants, these all the drugs which are being used for neuropathic pain. You can use all the drugs. Mainly you will start with the pregabalin, gabapentin, anti-epileptic drugs. That is the first thing. And if it is an acute pain, of course we will think that there is inflammation, and we will go for local anesthesia. Yeah, this one, your NSAID 1 course. Okay.
Hello, excuse me. Hello.
Yeah, tell me.
Yeah,
please.
What is the best anti-epileptic to be used for treating chronic pain? Lyrica, pregabalin, or what?
Yes. Pregabalin and gabapentin, only two.
Only two. Gabapentin also is good?
Yeah, very good. Gabapentin is safe.
What is the dose of gabapentin, please?
See, gabapentin dose, you have to start with a smaller dose always, so that patient doesn't get giddy, dizziness and fall down. So start with 100 mg TID three times, okay? And highest dose will become 600 mg TID, so 1800. So it is not needed, not that much needed. You go up to 900 mg if needed.
Okay, please also, what are the indications for ketamine infusion in chronic pain?
See, ketamine infusion only we use for systemic desensitization in the hospital, admitted for 2 or 3 times of session. Like if the patient have widespread pain of whole body and not responding to any drug, this type of patient we get sometimes, that patient's whole body is paining wherever you touch. It is the muscle, joint, tendon, head. Patient will have headache, arthritic pain, everything. In those cases where you find that nothing is working, then you can go for patient will come and admit in the hospital, and then you can start 4 mg per kilo of lignocaine, Zylocart. Okay, 4 mg per kilo lignocaine plus maximum of 50 mg of ketamine, and infuse over 1 hour. Sometimes I feel that there is a some ectopics coming or patient says, I mean, like if there is any vital instability, then we make it more slower and inject in 1.5 hours. Okay, so those things.
So 50 milligram over 1 hour only, not more.
No, not more, not more, not more.
Need ICU admission?
No, no, no. Daycare,
but ICU monitoring is needed. You have to monitor in the pulse oximeter and the cardiovascular monitoring. That is needed.
Yeah.
Okay.
Instability,
Because,
I mean, like some ectopics may come, so ECG monitor should be there.
because I saw in some places they transfuse ketamine overnight.
I don't know. Actually, there is no evidence as such. People may practice many things, but there is no evidence.
Okay, so 50 milligram over 1 hour only.
Yeah, and I will say only in severe fibromyalgia, nothing, nowhere else, because we should not.
When the other medicines in fibromyalgia is not working, then only.
Yes.
Only fibromyalgia, no other indication.
In sometimes in severe cancer pain also it is used, but again, patient, it cannot be used at home. It should be used only in the admitted patient where you can do the monitoring.
Sure, in the hospital. And the psychogenic pain also can help. It can help.
No. No, there is no pathway. I mean, psychogenic pain, no.
Okay, thank you.
Okay, okay, many questions. Okay, what is there any role of baclofen in low back pain? No, baclofen, yeah, I mean, there are some studies, of course, that baclofen also have some anti-neuropathic pain role, but it is not a daily prescription. We do not, it is not a first line drug for neuropathic pain. And mainly we use it for where there is spasm, say muscle spasm, I mean like Parkinsonism. In Parkinsonism, we will give baclofen. So if there is a muscle spasm, then only. Otherwise, its anti-neuropathic pain role is not that much proved. Okay. Sir, you want to add anything?
Yes, what you told right. That means baclofen has basically two mechanisms of action. One mechanism of action is basically it's an centrally acting muscle relaxant. So you can use it in the muscle spasm. And second is in some of the neuropathic pain, say for example, in the resistant trigeminal neuralgia who are not getting relieved with the carbamazepine. So baclofen has some role. That means it can be also used in a neuropathic pain. But again, how Dr. Chinmay told, it is not as a first line management. First line should be the other anticonvulsant, antidepressant, they should be the first line. And in resistant cases, you can try the baclofen. Otherwise, baclofen is mostly used as a muscle relaxant, centrally acting muscle relaxant, like in spastic hemiplegia, spastic paraplegia, and sometimes baclofen is also used in the pump, intrathecal pump, baclofen pump, and that is also used for this kind of things. Means spastic paraplegia, hemiplegia, these kind of conditions, you can use the baclofen in intrathecal pump.
One thing, another question is why steroids are given along with local anesthetic for nerve block? See, it is the steroid only we should give. Local anesthetic we give only for understanding that we have targeted the same, I mean, right nerve or not. If nerve block means, here I am talking about if it is a radicular pain and we are giving nerve block. In that case, steroid only will give because we are suspecting inflammation. Nerve as such, if you press a nerve like this, that will not cause pain, that will cause numbness. When people, you will see in carpal tunnel syndrome surgery, the surgeons, they take out the nerve and I mean like they can press the nerve also. I mean they can touch the nerve, but that doesn't cause pain. That is a numbness type of sensation. So I mean like when there is a radiculopathy, that means there is an inflammation. So for inflammation, we are giving steroid. And how it acts, just now I told you that through prostaglandin inhibition. And local anesthetic we are giving just to see that we have targeted the right area or not. If patient says just after injection that my pain is gone, that means if you have targeted L4 nerve root or L5 nerve root, you are in the right location. Okay, so that is it. So how do we prescribe for or do we prescribe for chronic migraine? It will be a long class. I mean, Dr. Devjyoti has headache.
Separate class.
There is a separate class of headache. Then they will, Dr. Devjyoti will say that what is the treatment of migraine. So, okay. Yeah, please tell me. Dr. Neha, something you want to say? No. Okay. Okay, we will go for demonstration now.
Hey, Chinmay, I have to
Yes,
go
sir.
quickly about the cryo. Just
Okay.
10 minutes for the cryo and then the demonstration of the machines.
Okay, okay, sir. Thank you.
Sir,
Yes.
do we need any cardiac evaluation before starting tricyclic antidepressant, sir?
What?
Cardiac evaluation before starting?
Tricyclic antidepressant, sir.
It is written in some, not as directly guidelines, I will say, but of course, if there is a history of any ischemia, ectopic, those things, no, then before starting, you can get one ECG done. Because tricyclic is notorious for sudden death cases. But yeah.
Thank you.
If there is no history, there is no need.
Excuse me, sir. Can I ask a question?
Okay.
Excuse me, sir.
Yeah, tell me.
Yeah, sir, actually in cases like IPOM, sorry, it's acute pain. For IPOM surgeries, patient is usually obese and there are transfacial sutures for the hernia fixation and it's extremely painful. I have given ultrasound guided tab block, both the sides and rectus sheath block. Still there is a lot of pain. Can I start with pre-op gabapentin and how much?
How long, but when we will start? I mean, gabapentin and pregabalin doesn't work before say 2 weeks time.
Actually, what she is telling, actually this type of studies, lot of this type of studies you will find it is already done.
Yes,
so when you were doing your post graduation,
yes, sir,
I think a lot of people at that time, maybe in 2009, 2007, so
yes,
they
sir.
have done a lot of this type of studies. Especially they are starting as a preemptive analgesia with gabapentin.
Yes, sir. Yes, sir.
Okay, but
yes,
as far as the chronic pain is concerned, gabapentin is mostly used for the radicular pains, and in those cases you can check those studies. Okay, previously that was tried, but the quality of studies, not I should say, everything is good, but most of the studies has shown that it has beneficial in post-operative pain reduction.
Yes, sir.
and long-term
Actually,
complications.
what else can I do for this pain? It's very painful for the patient, and the patient is obese also. So I'm a little worried about sedation for fentanyl pump or anything.
Yes, actually, this is a more nowadays we do not handle this type of cases, practically speaking. As in
Okay.
pain, it is rarely required.
Okay, sir. Okay, sir. So one more question. I started giving caudal CM guided caudal epidural and lumbar spine surgeries, and I used 0.35% ropivacaine 20 ml for this thing, and some of them they have around 1 to 2 hours of weakness, so neurosurgeon gets little scared, but after that their SLR is also very nice and they are completely pain free. So what is the maximum concentration I can use of ropin for post-op pain?
Again, the problem is the same, okay?
Yeah,
because nowadays we are
I
not
get
much
it.
practicing
I
that
get
part,
it,
okay?
but okay.
So in case if you require, you can place a catheter there as well.
Oh, okay, sir. That is a good. Sir, epidural catheter. Now
Yes,
I'm
epidural
using
catheter.
22 gauge spinal needle and CM guidance, so I can
see this. If you say about my experience, initially I used to do a lot of cases with the spinal needles. But what you will find when you are doing with the spinal needle, the chances of intravascular spread is much more common than the epidural needle. So once we found that, nowadays we commonly do with the epidural needle rather than the spinal needle.
Then how much can I use Omnipack? How much Omnipack should I give to see for intravascular spread?
Okay, usually a very small amount, 1 to 2 ml diluted omnipec is good enough. But for the initial period, you might not be able to distinguish this is epidural or this is subarachnoid or this is intravascular. In those cases, you can use up to 5 ml of up to 10 ml also diluted.
Okay.
If the kidney free function is
Yeah,
normal,
yeah,
nothing is going to happen.
yeah.
Okay.
Okay.
And even if it is intravascular, it hardly matters. Okay.
Okay, sir, and
If the
I've
kidney function is normal.
okay, sir, I've seen caudal is better than bilateral erector spiny block in these patients. I used to do see ultrasound.
You are blocking app when all the nerves are coming.
Yes.
Okay. So it is
Yes,
always
yes.
the side effects will be more, but chance of
but-
success will definitely be more.
Okay, thank you so much, sir.
Oh, sorry. So can you see me and can you hear me?
Yes, sir. Yes, sir.
And sounds are slide is visible?
Yes, sir.
Okay. So neurolysis, I told you earlier, for these two purposes. One is to reduce pain and second is sometimes for spasticity. And these are the different ways already I've discussed. Disadvantage discussed. One of these, this is very important, deafferences pain. Sometimes this is called neuritis pain. And this is because of the two mechanisms. One is crosstalk, another is your ectopic signal development because of the high density of the sodium channel. Regeneration of the nerve. This is very important. I discussed that. I'll be discussing when I'll be talking about the the next class. So it is not possible when the nerve body is dead. Regeneration is not possible. And second is regeneration is possible up to the 2nd degree. 3rd degree also regeneration possible with some faulty regeneration. And 4th degree, 5th degree regeneration is difficult. So I'll be coming to this in detail. So if you're looking about the nerve filaments, so nerve filament, each nerve filament has its endoneurium. And then some of the nerve filaments together is producing the perineurium. And then is your epineurium. So coverings of the nerve, there are 3 types of covering of the nerves. Endoneurium, which is covering the individual filaments. Then is your perineurium. Then is your epineurium. Now, what is called 1st degree? 1st degree is also called neuropraxia. Neuropraxia means here there is temporary conduction block. And normally, few minutes to few days is the duration with which the things will be coming back. And here, nothing will be, everything will be normal. There will be basically no, even if you are looking at the light microscope, in the electron microscope, you cannot see anything changes in the nerve. So that is your only physiological block, and that lasts for 30 minutes to 7 days maximum. Second is your axonotmosis, which is called 2nd degree. Here, the actions are basically, there is a discontinuity of the actions. And here, the nerve conduction is blocked for longer period. So it can be identified by your microscope, electron microscope. And here the effect lasts for 2 months to 2 years, depending on what kind of fibers is basically damaged. If it is a large diameter fiber, then the recovery is there within the 2 months. And if there is a small diameter like C fibers, then recovery takes up to 2 years. So remember, the axonotmosis gives the perfect regeneration because here all the covering, endo, peri, and epi, all coverings are intact. And this covering is vital for the nerve regeneration. Okay, so 3rd degree, when the endoneurium is damaged, then also there will be regeneration, but that regeneration will be faulty. What will happen? There will be crosstalk between these fibers, and there is a chances of the deafferences pain. But if it is a 4th degree, that means perineurium or epineurium, then chances of the regeneration is less. And even if there will be always very serious differences and pain. Epiduria, when it is discontinued or separated, then chances of regeneration is not there. So 5th degree, chances of recovery is not there. 3rd and 4th degree, recovery is there with some side effects, means there is an deafferences and pain. 2nd degree, perfect regeneration without any complications or side effects. And the 1st degree is only temporary conduction block. So now what is very important is when you are doing radio frequency, it gives longer pain relief. I told you 2 to 4 years. Why? Because it causes more than 3rd degree relief. So more than 3rd degree relief is giving a long pain relief at the cost of what? At the cost of faulty regeneration. That means the regeneration when it will be there will be some deafferences and pain. It is also called the neuritis pain. So that is possible if the degree of damage is your 3rd, 4th, or 5th degree. 2nd degree damage, there will be no everything perfect, no complication. And 2nd degree block is possible with your cryoneurolysis. And that is the reason why cryoneurolysis is nowadays becoming popular. So cryoneurolysis definition, low temperature to ablate the nerve, that is cryoneurolysis. What is the difference between the cryoablation? Cryoablation is mostly restricted for the tumor, but you can also call the cryoablation of the nerve is equal to your cryoneurolysis. But what is cryoanalgesia? Cryoanalgesia is basically for the 1st degree block. That means your 1st degree means your neuropraxia. That is by application of the application of the cold. That is called the cryoanalgesia. But cryoablation, cryoneurolysis are the term restricted when you are ablating enough. Okay, so these are the history, and then please go through that. That's just the principle. Principle is the gas outside the channel is very small. Under there is a constriction, there will be pressure, and the inner tube is large through which the gas will be. So because of this constriction, the gas will be expanded, and there will be at this tip there will be production of the cooling effect, and that is basically the Joule-Thomson effect. That is same for the refrigerator, air conditioning machine. So some gas is under constriction, is suddenly getting expanded, and the temperature will be falling down. How much temperature will fall? Depends on the freezing point of the gas. That means in carbon dioxide, maximum temperature you can attain, minimum temperature you can attain is -79. And when you are using nitric oxide, nitrous oxide, you will be able to go to -88. So now, earlier, the cryoablation is not new, but what is happening there, earlier the size of the lesion was very big. Fine needle was not possible, but now the needle is from 22 to 12 gauge, different types of needle. So size you can change it, and that is the advantage. Very small lesion to very large lesion. Like radio frequency, you cannot have very large lesion, but here everything is possible. And these are the different needles. We'll be showing it right now. And this is the size of the lesion. You see, this is a small size lesion is possible, and again, very large size lesion is also possible. So that is the advantage of the cryoneurolysis. So these are the cryo machines we'll be showing you. And another very important advantage is you can see the lesion. See, you have put under the ultrasound. Here you are doing it. It's a pleural now, pleural vessel. And for the generative pleural now, we are putting the needle here. And you see, when you are trying, you can see the lesion. So this ice formation, you can see it. You cannot see that in the for the radio frequency, but you can see the ice formation here. And below that, there will be acoustic shadow. So that is not there in the radio frequency, but that is possible in the cryo. So here also see another generative pleural now. So you can see the needle is there, and as soon as we are trying, so you can see the ice and you can see the acoustic shadow under the ultrasound. So here is another. You can see the big. This is a scar neuralgia. You can see the big ice and the acoustic shadow. So that is very important for this thing. This is a small video. Just quickly I am going. So here sacroiliac joint. So I am fast forward to putting the local anesthetic. So this was basically bilateral. Okay, you see this is the needle under the ultrasound, and later on what you will see. So after this cryo, this will be demonstrating it right now. and then you'll be able to see the acoustic shadow. So this is a carved needle. That's why you cannot see the whole length of the needle at a single, single view. And you'll be able to see the ice. Now ice is formed there. So that is the advantage. You can see exactly where you are producing the lesion. And in sacroiliac joint, normally we take the help of the both ultrasound and as well as the CM guidance. So CM guidance, you cannot see the lesion, ice formation. But with the ultrasound, you can see the ice formation. And there will be, the hyperechoic areas, and followed that, there will be acoustic shadow. So that is all. If you have any questions, quick questions with the cryo is fine. Otherwise, we are ready with the demonstration of the equipments. Any quick questions? Any quick questions regarding cryo? Hello.
The indication of indication
indication of the cryo and indication of radio frequency are almost same. I told you earlier, because of the the cryo probe was very large gauge, 12 gauge. So that is the reason why large size lesion was there. And disadvantage of the large size lesion is if you need a small lesion like trigeminal neuralgia. Earlier we could not think, but nowadays we are doing it. We have already done trigeminal neuralgia and small lesion, large lesion. So basically, if you're telling what is the future of the neurolysis, and I'll be telling the future of the neurolysis is in the cryo. That means radio frequency is maybe, this is my personal opinion, in future might be replaced with the cryo. The cryo, another advantage is radio frequency, when you're doing the lesion, the effect is not immediate. It will take 2 to 3 weeks time for its maximum effect to be there. But for the cryo, the effect is immediate on the table. And cryo is, we'll be showing you the needle is the probe. The cryo probe is basically, it's a blunt tip because the gas has to circulate and you cannot inject anything there through the so you can see this is a probe. It's a blunt tip, it's a blunt tip. So nothing you can inject, and it is not needed because you just give the local anesthetic, and then as soon as you are starting the cryo, immediately there will be pain. Basically, be having the pain free if your target nerve is very close, and you have to confirm it both by ultrasound and as well as the CM. In some situations, only ultrasound is enough, but in some situations, we take the help of both ultrasound as well as the CM. We are going to detect machines. Quick questions. I has already started giving them the meeting. So it is now 58. Other day also we are telling, but we have the patience. Till you are having the questions, we are there to answer your questions. So now let us see I go for the demonstration of the machine. আচ্ছা প্রথমে ক্রায়োটা দেখাচ্ছেন, ক্রায়োটা দেখিয়েছি নাকি প্রথমে? ক্রায়োটা হচ্ছিল, ক্রায়োটা দেখিয়ে দাও। না, এই মেশিনটা দেখাতে হবে। মেশিনটা অন করে দাও। You can unmute yourself and ask us questions. We are waiting for your questions. Okay, you see, this is the machine. This is the screen. This is the touch screen with which you can see the temperature will be when you are basically operating it, you are not operating it. So temperature, flow of the gas, carbon dioxide. See, there are two types of the carbon dioxide here it is, but hello? Microphone, speaker on? Hello, can you hear us?
Yes, sir. Low volume, sir. Low volume.
Low volume.
Please, loud and clear. It's loud and clear for me.
Okay, okay, okay.
Okay,
Very
fine.
clear.
Okay, so you can see the machine, no, cryo machine.
Yes, sir.
Yes, sir.
Okay, so this is the front panel. So this is the touch screen. You can see here the temperature, flow rate, and you can see the time. You can set the time, how long. Normally the cryo, each listen sessions, normally we do it for 3 minutes. 3 minute freezing and then defrosting for 1 minute. This is the normally standard one. And you can clean it, you can help it. And also there is this neurostimulation, like what we told in it. So normally what is in the radio frequency, we have sensory stimulations, motor stimulations. Here also you can go for the neurostimulations. So this is the setting with the setting, you can change the freezing time, defrosting time. So everything we can change that way. And as a whole, the machine, this button is to increase and decrease the intensity. And this is your carbon dioxide cylinder through which, so carbon dioxide cylinder, it is attached at the end of the machine and gas is coming from that cylinder. And here it is coming, and here we have to attach the probe. So this is the probe. I have already shown you different types of probe. It has to be attached there. So you have to open it there and attach there and fix it. And then it will be putting inside the body. And here also there is this part which will be showing, going for the current. So this is, you see, this part, some part is insulated and some part is open, non-insulated. So why this insulation is needed? Insulation is not needed for the cryo, but this insulation is for the stimulation. So when you are stimulating that, to understand whether you are close to the nerve, you need to have a small area. Otherwise, if the whole length of this probe is exposed, then there is no meaning. You cannot stimulate the nerve. So this insulation is not for the cryo. For the radio frequency, it is needed. But for the cryo, this insulation and non-insulation is because just for the stimulation, because the same probe can stimulate it to understand that you are close to the nerve. And these are the different kinds of probe you see. So starting, this is a large size lesion. Here you can see around 10 millimeter. So can you see it? So you see this is a 10 millimeter probe.
Yes, sir.
Okay, and it's width of the lesion will be also approximately the 8 millimeter will be the size of the lesion. So similarly, there are different size of the probe. So this probe is width is around 6 millimeter length, and size wise it will be only around 3 to 4 millimeter. The same way, there is a very small, this is a 22 gauge needle. You can see this is a very small 22 gauge needle. 22 gauge, very small, and it will be producing very small size lesion. So length will be around 3 to 4 millimeter, and width will be only 2 millimeter. That means with this kind of needle, we can have a very small kind of lesion. So this is again another 22 gauge needle, not needle, sorry. Cryo is always probe, 22 gauge, and almost similar to this one. Only this one. Only difference is here is the length of the probe is smaller. Otherwise, the gauge and exposed tip is all similar. And this is another very unique one. This is a carved one. I was showing you in the sacroiliac joint. So this probe is specifically carved probe for the sacroiliac joint. It can produce a large size lesion of around 8 centimeters. So what is the advantage of that? That means with the single probe placement, you can ablate whole of the medial border through which the lateral branches enter into the sacroiliac joint. And it has a very high success rate. Already we have a publication. So the first ever publication on the SI joint on the cryo. So already published in the literature. And we are having a larger study with this cryo probe in the sacroiliac joint. It is giving the fantastic result. Advantages, I told you, the large size lesion. And as we are telling, large size lesion in the cooled radio frequency has the advantage. Same way, the cryo can produce even larger size lesion than the cooled RF40 is doing. So this is little bit of around the cryo, and then we'll be showing you the machine of the radio frequency. Machine down. So again, there are different companies machines are there. This is one of the company, but the basic features are same. Machine to machine, some of the features are to close up. Machine to machine, some of the knobs and the touch screen might vary, but otherwise the basic primary features are all same. So here you see This is a probe selection. So what we can do, 1 or 2 electrode monopolar. So monopolar can be with the 2 electrode. Monopolar 2 electrode means it is a multi-channel, means 2 monopolar listen together simultaneously. I told you that is another mode how we can use it. So that is one mode. Second mode is we can use this mode, 2 electrode bipolar. So here there will be 2 electrode, but there will be bipolar, and there can be, 1 electrode bipolar, means the circuit will be completed between the 2 needle, but listen will be only in the one electrode. So these are the different kinds. So most commonly we do this one, 1 or 2 electrode monopolar, and then this one is your stimulation. Means what you can do here is your 2 hertz. 2 hertz means I told 1 to 2 hertz is for the motor stimulation, and by increasing this knob we can increase the voltage, and we can see how much is your, means smaller voltage means we are very close to our nerve, and that gives the better result in the and if you are increasing the, suppose too much, and then you are getting the stimulation, it don't have any value. Ideally it should be less than 0.6 voltage. So 0.6 voltage, if you are getting the stimulation, means you are very close to the knob. So motor stimulation, and then you can change it to the sensory stimulation. Sensory stimulation means 50 hertz current, and again same way you can increase, and this you can do these things. So sensory stimulation and motor stimulation, these are the prerequisite to understand that your needle is close to the nerve, which is your target, and away from the nerve, which is not your target. Then next part is your conventional radio frequency, and this is your pulse radio frequency. So here the pulse radio frequency, you see by the sign you can see there is some, the high frequency current, then silence, then high frequency current, and here you see the temperature and the duration here is set. Temperature here you can see 42 degree, and you can change the the other parameters. As I told you, 2 hertz 20 millisecond is normally, see the 20 millisecond here it is written fine. I don't know whether you are able to see it. So 12 degrees centigrade is the temperature, and 20 millisecond is each pulse width, and 2 hertz means current is delivered 2 times per second. That is the standard parameter for the pulse radio frequency, but you can change it. Like if you are making it, by making it, you can change it to the different parameters for the pulse radio frequency. That means you can change the voltage, you can change you can change the pulse width, and you can also change the frequency of pulse radio frequency. So now, so default setting is 2 hertz pulse, but you can change it. Restore default setting, yes. Oh, exit. Okay. So now we are going to the monopolar. So monopolar, there are 2 options, as I told you, choosing the electrode. Here what I have chosen, 2 electrodes monopolar, means there will be ground pad, and then, but here I can choose the 2 electrode bipolar also. We'll be on the chicken, we'll be demonstrating it. 2 electrode bipolar, because you don't have any ground pad, we'll be putting 2 electrodes on the chicken, and we'll be showing you. So now when you are telling 2 electrode bipolar, and now we are going here, and now you can see the 2 electrodes are showing, the 2 different tip temperature are shown. So now the tip temperature, we can go, we have chosen at 75 degree, I can make it 80 degree, I can change it further by reducing, decreasing, I can change it. You can see this is changed. So I am changing, making it 85 degree. And you can see the tip temperature, one tip temperature is 20 degree, another tip temperature is, so you can see the very connected. Okay, so now the 2 electrodes are placed side by side, and now we are starting it. So this is a piece of chicken with which there are 2 electrodes, and you can see here also in the machine that we are starting it. Machine দিকে একবার তাক করো। So 85 degree temperature, and you can see the 2 electrodes are there. So now we are starting it.
Below 20 চিকেনটা গরম করতে হবে।
Actually, if the body temperature is not so cool, so here the temperature is below 20 degree, that's why the machine is not starting. Okay, so we can start it. আচ্ছা মনোপোলার দিয়ে দেখো তো প্যাডের উপরে চিকেনটা রাখো। We are trying to show you the monopolar. Let me see whether it is starting or not. So normally body temperature is 37. So machine is set like that. If the temperature is too low, then the machine is not starting. There are certain parameters. If the impedance is too low or too high, then also machine will not start. Electrode mode not correct. দুটো হলে তো দুটো আলাদা আলাদা হবে, তো অসুবিধা কি আছে? হ্যাঁ ওই জন্যই হচ্ছে। ও ও
19 ডিগ্রিটা খুলে ফেলো। 19 ডিগ্রি প্রবটা খুলে ফেলতে হবে। এটা একটা খুলে দেন, ওইটা 19 ডিগ্রি খুলে ওটা তো 20ই মাত্র। হ্যাঁ ঠিক আছে, 20 তো দেবে এটা। একটাটা বন্ধ করে দিন। So we have started.
So now you see the tip temperature is rising. We have set temperature at 85, so it will go up to 85. And after that, the power is, you see the power, it was there 3.5 and now it is reducing. You see power is reducing 2. And then to keep it constant, it will go on fluctuating. Initially it was 3.5, now it has come down to 2.7. So you look at this, it goes on fluctuating. Why it is fluctuating? It is fluctuating to keep this temperature at a constant level. And you see power is reduced. And that is the reason why your size of the lesion will not be bigger with this radio frequency, because you cannot deliver the current at a high power. So here you see weightage is further reduced to 2.3. At the beginning it was high. When the temperature was rising up, going up, that time the power was higher. এখানে দাও, লিসেন হচ্ছে তো হয়তো ডিপার হচ্ছে। হ্যাঁ, you see now there is getting, you know, so you see this is the listen, you can see the
এখন একদম কাছে নিয়ে রাখতে দুটো লিসন টু নিয়ে গরম হয়ে গেছে।
হ্যাঁ মনে হয় দেখি। So we are trying if the two listen is possible, but actually ডিমের মধ্যে না ভালো দেখা যায়, ডিমের সাদাটার মধ্যে। ওই জন্য নরমালি ডিম করি। চিকেন বললে বলে চিকেন বললাম। আচ্ছা এটা তো লাগাতে হবে। হ্যাঁ okay, একবার ডেকে দেখিয়ে দাও। So now we have because the temperature has raised, so now you are able to start. You see the two electrodes, one electrodes normally goes very higher, another electrodes will be going little bit less. So you have taken the bipolar with one lead will be temperature going will be higher, and you see here এখানে ফোকাস করছি কিনার উপরে। So the two electrodes bipolar, but one electrode will be having the lesion here. You can see the lesion is going on, and you can see that it is getting paler. So that is the lesion. You can easily understand the color change, surrounded color and the color where there is lesion. Chalo, take. Okay, any questions if you are having, you can ask the questions. Okay, you can have a close look about the chicken, how the color is changed. And you see, it is not a very big size lesion. It is basically magnified view. Tip is not and you see, tip is not, you see the tip is here. So lesion is not beyond the tip. Basically, tip was like that. Inside you are unable to understand. But what is important that because it is not a cool dead frequency. In cool dead frequency, there will be lesion beyond the tip. But here it will not be going beyond the tip.
Sir?
Yes.
How painful will it be for the patient, sir? It's
very painful. So you have to, like cryo is not painful. Cryo, there is no need of giving local anesthetic around the deeper structures. But here you must be numbing it nicely. So first what you need to do, what you need to do, that you first confirm your needle position with the sensory stimulation, motor stimulation. You cannot give local anesthetic at the beginning. Sensory stimulation, motor stimulation should be completed first, and then only you can give your local anesthetic. But before the lesion, you must be giving local anesthetic. Otherwise, it is extremely painful. But for the cryo, you need not give any local anesthetic because cryo is not a painful procedure.
Thank you, sir.
Sir, what is the advantage of cryoneurolysis over cooled RF in respect to the lesion size? Both
cryoneurolysis, you can go for the, you can any size lesion. Means, as I told you, 8 centimeter long needle is possible, lesion is possible for the cryo, but for the cooled radiofrequency you cannot think. Cooled radiofrequency maximum size of the lesion will be, it is a spherical lesion, and diameter will be 1.5 centimeter, 15 millimeter. That is the maximum size possible. But for the cryo, you can go any size lesion is possible. That is the advantage of the cryo. But disadvantage of the cryo, the duration of pendulum will be longer with the radio frequency. But as I told you, the number of years of pendulum is longer with the radio frequency, because it will give 2 to 4 years of pendulum. At the expense of what? At the expense of, sometimes, not always, around 1 to 5% situation, there might be deafferences pain, increase of pain. But for the cryo, because it is producing the second degree lesion, so there will be no deafferences and pain. And second advantage of the cryo is you can have any size of the lesion. You have to choose your probe appropriately to determine what kind of lesion you wish to produce.
For the size of the lesion, will there be any damage to the surrounding structures, or there is no?
You have to. There is no universal rule. You have to understand that what kind of, suppose you are doing a Gasserian ganglion cryo and you are doing a sacroiliac joint. Sacroiliac joint, you are producing a long lesion, but you cannot think of it in, and you have to understand what are the surrounded structures are there. So you have to choose your probe depending on your anatomical knowledge. There is no universal thing what will be fitting for every neurolysis. So cryoneurolysis, for each individual, each nerve, you have to understand that what are your anatomy, what are the surrounded neural structures, and based on that, you have to select your probe.
Thank you, sir.
Okay, so if you have further questions, it is already 9. Otherwise, you can, if you have further questions, you can put on the email also, or in your, the individual, you can ask us. So the next day before the class, we can answer the questions. And let us say goodbye today. And happy Guru Purnima to all of you.
Thank you.
Okay, thank you very much. And good night.
Thank you, sir.